This is the summary of anti-hyperlipidemics. This is for your board review. You're supposed to learn 7 different classes of drugs. Out of all these, first line is statin. You must learn the mechanism of action, class name, indication, and adverse effects. So first 4 classes are working or target cells are hepatocytes, statins, PCSK9, fibrates, and ATP citrate lyase inhibitor or ACL inhibitor. So all the 4 classes drugs works inside the hepatocytes, but different mechanism we will discuss. Cholesterol absorption inhibitor and bile acid sequencer, they work inside your intestine, small intestine. And vitamin niacin works inside your hepatocytes. All these drugs are having different indication for cholesterol controlling to save cardiovascular risk. So statins, indicative drug is atorvastatin. That is a long-acting, high-intensity statin, very effective drug. Okay, commonly used, like a very cheap and about $1 per day you have to spend for that drug. It is very good one. So mechanism of action: statin inhibits HMG-CoA reductase enzyme in the hepatocytes cholesterol synthesis pathway. But if you compare statin with the 4th class ACL inhibitor or ATP citrate lyase inhibitor, here also it is a enzyme inhibitor, but it is an entirely different one, exactly same pathway it is targeting, that is the cholesterol synthesis pathway, but this one is working on the ACL enzyme. So ACL enzyme and statins HMG-CoA enzyme both are involved in the cholesterol synthesis. Therefore, this is, if you combine statin with ACL inhibitor, that is atorvastatin with bempedoic acid, that is called sequential blocking. Okay, just to understand that. So statin mechanism of action is good. Then let's talk about atorvastatin. This drug is with about 14 hours of half-life, and its metabolite is also active. Therefore, you need to have like once daily dosing is good. And another point to remember, this has a CYP metabolism, CYP3A4 metabolism. So therefore, if any patient taking any drugs related to that, you may need to do the dose adjustment. Or there is another long-acting drug available that is called rosuvastatin. That is a really very good drug. That is also hydrophilic. Atorvastatin is lipophilic. Therefore, it can distribute into the tissues really, really fast. But one thing is, when it gets into the muscle, skeletal muscle, very quick, it can cause myalgia, myopathy, and all the complications. But compared to atorvastatin, rosuvastatin has lesser myalgia or muscle-related adverse effect. Of course, they can develop because it will get into the muscle, but compared to atorvastatin, that will be less because that is a hydrophilic drug. That was also a hepatocyte specific drug. Hepatic cells mainly actively uptake that drug compared to atorvastatin. Atorvastatin lipophilic, so it is easily diffused. That is the reason this class of drug has a major adverse effect. Common adverse effect I want you to study, that will be myalgia, sometimes mentioned in board exam, myopathy, associated the conditions. So what happened is, the same HMG-CoA reductase enzyme inhibition happening in the skeletal muscle also. But in skeletal muscle, that is actually a high energy required tissue. Therefore, those tissue will be suffering faster. So when this statin get into the muscle, skeletal muscle, and inhibit CoQ10 enzyme, so it's going to affect the mitochondria, and that's why the muscle going to die. Sometimes in some patients, that is a rare condition, but still, especially if you have a higher dose, patients can get those muscle tissues going to die, and it's going to break down. It is called rhabdomyolysis. You can even get the test as elevated creatine kinase. Especially if you ever notice elevated creatine kinase, you supposed to stop this drug and switch into any other classes, because that will be a life-threatening adverse effect, because the patients can, because of all these created, everything is filtered through the urine, and the kidney get into trouble, all the complications. So keep in mind. So we learned about the statin mechanism of action. Statin, the class name, most commonly because it is a first line, it effectively decreases the LDL cholesterol. Adverse effect, because this drug is, even the lipophilic or hydrophilic drugs, it can get into the muscle and cause myalgia, and common adverse effect about 20% patients, but severe adverse effect, life-threatening, can be rhabdomyolysis or kidney renal failure. Okay, so if you remember, if you wanted to understand, connect with the indication, always remember, because HMG-CoA completely stopping the cholesterol synthesis in the liver or hepatocytes, the cells are actively recruiting LDL receptors to pick up all the floating LDL from the blood, because they run out of cholesterol. So that is why actively they pick up all the blood cholesterol from the flowing blood into the liver. Therefore, blood cholesterol level will be controlled. If the patient taking this drug and exercising and diet control, that will be a very good drug to regulate the cholesterol. The second class, that is actually PCSK9, and if we compare PCSK9 inhibitor with a statin get about 50% reduction of LDL cholesterol. It's reasonable and well tolerated drug, but the PCSK9 inhibitor is very effective. That is about 70% of the LDL cholesterol control is possible by this. PCSK9 is actually called the LDL receptor degrader. That means after doing the job by the LDL receptor is supposed to degrade inside the hepatocyte. That is done by this enzyme PCSK9. But the PCSK9, if it is not doing its job, all these LDL receptors will be there to pick up all the maximum cholesterol or LDL from the blood. That is why smart scientists designed this antibody that is called PCSK9 inhibitor. They use this. The drug name is alirocumab. Alirocumab is a monoclonal antibody mAb that will be specifically go and bind and block PCSK9 and degrade it. It's like chopping it out so that it will not degrade the LDL receptor. Keep in mind, alirocumab is a well-tolerated drug. Only problem is this is a recent class because it is very expensive. It is about about $15 to $20 per day you need to spend to use this. But one thing is it has a very easy administration. There is no oral drug, of course. Subcutaneous administration is available. The reason I supposed to mention in the class, I forgot that point. Half-life is about 20 days. That's a long half-life, right? So therefore, even we have, if it is little bit higher doses, we have doses for once in a month administration. That is really a different factor to remember. Then PCSK9, it will allow a lot of LDL receptors to express on the hepatocytes so that they can pick up the all these floating or LDL flowing in the blood. So keep in mind about that. Then pharmacokinetics we already mentioned. this drug actually metabolized by regular it, you don't even, the liver function is not affected by this reason. It is just like an immunoglobulin IgG breaking proteolytic enzyme that will just break down after the use. So that's a very good factor. The reason is especially statins, you must need a healthy functional liver, right? Some of the pro drugs, if you are using like a simvastatin, like pro drugs always needed like a activation, metabolic activation to function. But even atorvastatin, all those are metabolized by the CYP enzyme. Therefore, keep in mind, you need, especially the patient taking alcohol or liver toxic component that can interfere with that drug. So that's a one difference. But keep in mind, even though the first line drug is statin, atorvastatin, alirocumab is a very good drug, PCSK9 inhibitor, well established one, and hopefully in next 5 to 10 years we can use it as like really cheap, and somebody will come up with some oral drugs. Okay, then the third one, remember the first section, first 4 classes I was talking about, the target is hepatocytes, right? All those 4 drugs working inside the hepatocytes. So fibrates, that class, easy, the drug name is fenofibrate. Okay, there is another drug called gemfibrocil. That's actually, when you combine with the statin, it has like really more toxic, and it causes more myalgia and muscle pain. Therefore, that is not a good drug to combine if a patient needed additional coverage, or if the patient cannot tolerate statin. If you have to add on another drug and use fibrates, the problem here, it can cause more myopathy. But fenofibrate has some exception. If it is a lower dose, it is okay. So let's look at the mechanism of another point. I forgot to mention the PCSK9 indication. PCSK9 alirocumab indication. It is indicated for cholesterol. It is a cholesterol lowering drug, so it can be used for LDL regulation, but FDA approved for familial hypercholesteremia. Reason, especially in specific type of familial hypercholesteremia, because of the chromosome 1 mutation. PCSK9 in some patients will be too much, like really activated, and produce like a exponential number of PCSK molecules, so that they started chopping down all these LDL receptors. Even the regular non-PCSK related hyperlipidemia, you can use PCSK9 inhibitor because of its available role of LDL receptor expression. Okay, understand that point. Then anyway, fibrates or fenofibrate indication is, this is the one drug indicated for extremely high level of triglycerides. If a patient has too much, like above 500 milligram per deciliter triglyceride, FDA indicated fenofibrate or fibrates. Reason, this drug can activate nuclear factors PPAR alpha, which can stimulate lipoprotein lipase. That lipoprotein lipase will help to boost lipolysis. Therefore, stored fat will be breaking down, so that all these cells in our body, tissues in our body, can utilize. That is how the patients get a lower level of little bit LDL, little bit elevated, they can boost little bit of HDL also. But the main factor is they can reduce like really good level of triglycerides. Okay, that's a major indication. And another point, the same mechanism can cause some adverse effect. I want you to remember 2 things. So one is, bile stone formation, because board like to ask that adverse effect of this drug. The reason is when PPAR alpha activation happens, this can alter the bile acid synthesis pathway, so that bile acids will produce only very less with this class of drugs. Therefore, all these cholesterol start accumulating inside the gallbladder, so that it will be bile stone formation will be there. That is a one point. Another point, sometimes board ask, or you can study that why you should try to avoid statin combination with the fibrates. The reason is because, or why, if you have high dose of statin and high dose of fibrates, it can increase the risk of muscle pain. The real reason is this can increase the fatty acid oxidation. This fatty acid oxidation inside the muscle can cause a lot of how do you call, other muscle pain. That's a major factor, because remember I was talking about it's breaking down tissue fat and available to take up by the tissues. So when the fatty acids start accumulating and oxidation stress giving to the muscle, that's why that's an entirely different mechanism of muscle pain in fibrate induced condition. But in the statin induced, it will be, of course, with the specific indication mechanisms like HMG CoA reductase pathway and CoQ10 pathway. Okay, so understand, that's a reason. I think we mentioned all those about these drugs. Then next one, last one, which is targeting the hepatocytes, that is the new class 2020 release drug, bempedoic acid. Bempedoic acid is a very well tolerated pro-drug. That's a very good thing. This drug will not cause any muscle pain or anything. There is no muscle related adverse effect. Reason, this drug has to be metabolized to change into an active drug. This drug cannot be metabolized in the muscle, but instead it work inside the activated inside the hepatocytes. Inside the hepatocytes, the same pathway, like cholesterol synthetic pathway, early, just before the HMG CoA reductase pathway, just before that, we have a step where we have to convert this citrate to acetyl CoA. That is the step blocked by this enzyme ATP citrate lyase. That enzyme is inhibited by this inhibitor. That is why it is called ACL inhibitors. Bempedoic acid, well tolerated drug. Maybe this is also a future drug we can look forward to. You can use it for statin intolerant patients, or you can even give it as an add-on therapy, so that we can get a sequential blocking. Okay, good. So we covered most of it in this section. Then the next two, so the liver part is done. Next is intestinal part, cholesterol absorption inhibitor. That is a unique type of drug. Very for recently last couple of years, it is a lot of articles are coming out saying this is actually a lot of clinical studies, evidence-based research showed that this is very effective. Of course, you cannot compare with a statin or PCSK9 inhibitor like a 70% by 70% by PCSK9 inhibitors, right? 70% LDL level control and about 50 to 55% by statin. No. But cholesterol absorption inhibitors inhibit about 20%. Very less, low level, especially patients with a very mild elevation, you can prescribe this drug even if you want it as a monotherapy. But the always primary is a statin therapy. Therefore, if it is if the patient is not tolerating or if they are having resistance or anything, you can add this drug. Another thing, if the patient get all the maximum dose of statin, if you need to add another drug to regulate the cholesterol, you can use this cholesterol absorption inhibition. So let's talk about what happens. Very easy one. Ezetimibe, that's the drug name. Ezetimibe is a cholesterol absorption inhibitor in the intestinal brush border. That's how they named the drug. That's why I wanted to study. That will be easy for you. MIB. See, IB, intestinal brush border receptor inhibitor. So this is actually this drug. When you take oral drug, it's going to go to along with your food. It's go and bind all these small fat digested components, and it's going to be blocking. How? In the intestinal brush border, this drug going to bind on a receptor. That's how it's going to block. Okay, so the receptor name is NPC1L1 receptor. It's good for you to remember. Sometimes board may ask. I don't remember whether they ask. I never seen a question, but what if they're going to ask? Because we study all these PCSK and all those specific enzymes. So therefore, I wanted to study that NPC1L1 receptor in the intestine, brush border cells. Okay, that's what the point. Cholesterol absorption inhibitor is ezetimibe. Easy to understand. What is the adverse effect of this drug? If you eliminate a lot of fat into the feces, that will become, end up in diarrhea. Right? The next class is bile acid silencer or bile acid sequestrant. This actually the drug name cholestyramine. It's like cholesterol. That's how we pronounce cholestyramine or cholestyramine. So this drug is actually indicated for reducing cholesterol, LDL. It can also given as an add-on therapy. And one unique indication of this drug is pregnancy. All the other drugs in anti-hyperlipidemics are contraindicated in pregnancy because it is not at all safe. Only bile acid silencer or bile acid sequestrant is okay. Example drug name cholestyramine. Cholesterol, think that way. So this drug is okay with that. What is the reason? Cholestyramine and all the other bile acid silencers are large resin molecules. They are not absorbed through the intestine. Okay. The site of action is inside the intestine, duodenal wall, where it's going to stay, but as soon as bile secreted into the duodenum, bile is negatively charged. Cholestyramine and all the bile acid sequestrant are positively charged. Therefore, as soon as it finds that molecules, bile acids, this is going to bind and precipitate in the duodenum, and then it slowly moved into the colon. Keep in mind, this drug can normally healthy condition, bile supposed to be reabsorbed, right? Bile acids about 90% reabsorbed through the enterohepatic circulation. That is the step we are blocking. Therefore, our liver will be running out of bile acids. So the liver gives signal that okay, bring more LDL and start producing more bile acid. So it keep producing. That is how its effect of reducing cholesterol. But 2 points to remember why this drug is okay in pregnancy. This will not absorb into the systemic circulation. Okay. When you stop there and look at the previous class, cholesterol absorption inhibitor ezetimibe, that drug can absorb into your systemic circulation, and it can pass through the placental barrier. Therefore, this drug cholestyramine will not pass through the placental barrier. That's why it is okay. Generally, pregnancy people don't get hyperlipidemia, but in case if somebody has, this is the one class and only one drug FDA indicated. Okay. Then other points to remember, major points. This drug can also cause high triglyceride in patient. That will be an adverse effect. Okay. So what happened? There are two adverse effects I want you to remember. One is triglyceride. What happened is bile acid silencer are going to trap all the bile acids and leave into the feces, right? So the liver is like giving signal to produce more and more bile acid. These signals will be so fast. So keep in mind, some of the enzymes which produce bile acids share the synthesis of triglyceride. Therefore, triglyceride production will be also higher. So keep in mind, bile acid silencers, one of the adverse effect is increase triglyceride level. Not in everybody, but if it is lower dose, it will be fine. But for long term, higher dose, it can cause high triglyceride. Reason, it's very simple to understand. That's the same enzyme involving in the, because bile acid is losing through the feces, so liver is giving signal to produce too much more bile acid. Why? Go pick up all this. We recruit a lot of LDL receptors and go and pick up all the LDL molecules. Then it's going to produce a lot of bile acid. And last point in that, why it is okay to pregnancy? It will not absorb. It's going to completely removed through the small intestine to the large intestine. Inside the colon, this can stay because it is a resin and it's it's going to stuck there with a. That's why most of the time patients can get flatulence and constipation. That is an adverse effect of this drug. Okay. Keep in mind that is an add-on therapy generally, but in case if it is a pregnancy, you cannot add any other drug, so therefore this will be a monotherapy. Then the last class, vitamins. Vitamins, the older drug. This used to prescribe because you need to, this is vitamins, right? So you need to prescribe really milligrams, high dose to regulate cholesterol. So the problem here is this its effect is, if you really calculate all this, weigh all the adverse effect, because you are adding like a lot of tons of vitamin into the body, that is so dangerous for your body. So that is another reason. And also if you compare with the other drugs, it's compared to other drugs, its favor is falling. Most recent last couple of years articles and evidence-based research proved that this drug is not the go-to drug. Maybe the smart doctors don't prescribe this drug. That's I should say. Niacin. How this drug work, the site of action. I wanted to distinguish niacin from all the other drugs. First 4 class site of action was hepatocyte. 5 and 6, 2 classes working, the site of action was in the intestine. And vitamin niacin, this will work in the adipocytes. Inside the adipose, it's going to inhibit an enzyme called hormone sensitive lipase. So what happened is, this niacin going to block the adipocytes, telling don't give any fat, you are not going to release any fat, so that liver will force to pick up all the LDL from the blood. That's what literally they are doing. Niacin going to block a lipase enzyme, therefore that this going to in turn, the after effect will be our liver is trying to work hard, because whenever needed, usually adipose tissue usually provide based on the hormonal release, but now niacin can block. So actually mechanistically it works. And if you think about it, it can increase about 35% of HDL level and also decrease about 10 to 20, more than 20% of triglycerides. So for triglycerides and HDL level regulation, this is okay. But if you compare with all the other drugs, its LDL regulation is very low. So what scientists are saying is, that it is not giving any cardiovascular protection. That is a major point. Okay, this is a cardiovascular pharmacology section, so therefore there is not much cardiovascular protection. And if you are giving these high doses of drugs to regulate cholesterol, what happens is the patients can get gout in future. The reason is this drug can inhibit OAT transporter in the nephron. Therefore, uric acid deposit increase, hyperuricemia in the body, and it will end up in producing gout in certain, especially elderly patients. It can be common. And another point to remember is this can also cause cause hyperglycemia, right? Nobody wanted hyperglycemia when you take another drug, right? So this can cause, the reason is the extra fatty acids can, and the oxidative stress can kill pancreatic cells, pancreatic beta cells, and later it can make insulin resistance. Keep in mind, this is specifically to the structure of the niacin. It can cause multiple adverse effects, but the most commonly asked adverse effect for the board is flushing. The reason is because of this, this has an ability tendency to dilate superficial blood vessel, facial part, and all the skin. It will be dilated, so it can cause flushing. So this can that is one of the adverse effects. So like you can take aspirin and regulate that. And yeah, so these are the major point, and I think this is really an easiest lecture. Only 7 class, but the first line is statin, and if you can compare all those with that drug, it will be good. If you're asking me the best drugs in this group, of course statin first line, then PCSK9 inhibitors for the specific role, so that LDL receptor is not degrading. That's a good drug, alirocumab. Then cholesterol absorption inhibitor, ezetimibe, without much adverse effect. Some patients don't get much diarrhea or anything, so that is a very good tolerable drug, especially if you wanted to add, or if you have any other tolerance of other drugs, you can use it. Then fibrates, I told you, specific indication is triglycerides, right? If it is really too high, above 500, right, then only you can give fenofibrate or fibrates. And bile acid silencer will not absorb through the intestine, therefore you can use it in pregnancy. Last one, fibrate, they commonly asked for the board like a gallstone. Then they add-on therapy similar to statin mechanism of action, cholesterol synthesis inhibitor. HMG-CoA reductase inhibition is statin, but ACL inhibitor is ATP citrate lyase inhibitor, that is bempedoic acid. That's a new drug. This is like a PCSK9. This has a lot of future, but now it is so expensive. Keep in mind, this doesn't have any muscle pain or anything reason. This is a pro drug. Once it get into the muscle, even it's not going to be activated. It has to be activated in the hepatocytes. That's the reason. But the regulation of LDL, or the bringing down LDL level, is not super high like a statin or PCSK9 or anything. That's the reason. This is actually now a add-on therapy. Usually, like if a patient already taking maximum statin level, or patients with intolerant taxane, you can add this drug with some other, ezetimibe or cholestyramine or something like that. Okay, so alirocumab, this is the expensive one, injection once in a month or once in 2 weeks, because 20 days of half-life, that's a long half-life. And I think this is AntiHyperlipidemics. Hope this will help you. I tried to shorten, but I tried to reduce it into 20 minutes, but I think it may be 40 minutes. Anyway, thank you.